Hello, everyone. Thank you for spending a little time with us tonight in what should be a really exciting evening, talking about one of my favorite topic areas, and that is orthokeratology and myopia management. My name is Craig Norman, and over the last year and a half, I've had the pleasure of being the moderator for this webinar series that has been put on by ABB Optical Group that has been really quite interesting for all involved in different areas of the contact lens field. Part of our interest this evening is the speaker, who I think for those of you that have had the opportunity to hear Dr. Maria Liu before will agree, is one of the top experts in this field of ortho-K and myopia management. So with that, I'd like to introduce, if I could, Dr. Liu to you this evening. She's an associate professor of clinical optometry at UC Berkeley. Her research and clinical expertise is in the investigation and utilization of novel contact lens designs and pharmaceuticals in myopia control. She's the founder and chief of the myopia control clinic there, the first of its kind in a teaching clinic, and it now serves as a model for optometry schools across the country. Dr. Liu is originally from Beijing, where she was a practicing ophthalmologist before relocating to the United States about 20 years ago. She obtained her MBA prior to her optometry training at Pacific University College of Optometry, where she completed an MPH and a PhD there. Dr. Liu, we're really excited to have you here this evening, and thank you for spending some time with us in the audience.
Good evening, everyone. It's my great pleasure to be included in this program. I'd like to take this precious opportunity to share with you over the past maybe 10-15 years what we have learned regarding the role of orthokeratology in the field of myopia control. And I'd like to start with my financial disclosure. I do receive consulting fee from Paragon Vision Science, now a Cooper Vision company, as well as Axial China, but I have no commercial interest in any of the products mentioned in this presentation. So we all know there are numerous clinical studies investigating the role of ortho-K in myopia control. But if we're only limiting the study designs to randomized control trials and having a longer follow-up duration of 2 years, we can see most of the systematic reviews would have the following 7 studies included. And out of those 7 studies, we can see they all reported a statistically significant positive anti-myopia effect from ortho-K lenses. And in this red box I'm showing here, we can see over the course of 24 months, on average, ortho-K lenses is able to inhibit the axial elongation of about 0.26 millimeters compared to the spectacle control group. At the first impression, you may think this is such a small difference, 0.26 over 2 years, which is roughly about 0.13 millimeters over a year. But keep in mind that ortho-K for myopia control is a long-term commitment, both from practitioners as well as from patients and their parents. And from what the past literatures or the studies have implied, ortho-K lenses does have a sustained anti-myopia effect. So if we're actually keeping the patients in these lenses for over 5 or 10 years, the overall impact on the axial inhibition will be very, very significant, and it will play a very critical role in minimizing the risks of retinal complications. But I do want to also bring your attention to the red box I'm showing on the left bottom corner here. This is a test for the heterogeneity of the anti-myopia outcomes of all of the studies. So from this highly statistically significant result, we understand that even within the same study, we see a very wide range of confidence interval, suggesting for all of the patients or subjects receiving the ortho-K treatment, we see a significant individual variability to the treatment. And certainly there are very significant differences in terms of the overall efficacy across the studies. And so today I'd like to focus our discussion on what are the major major contribution or components that can actually explain those significant individual variability. So if we're talking about the major source of variance of the effect size, the #1 factor is related to our current challenge in defining the anti-myopia efficacy, especially with axial length as the outcome variable. We all know that for Orthok treatment, it's usually not very feasible to ask patients to be completely washed out from the treatment, and so that we can get a very accurate refractive reading. So most of the time, we'll have to rely on the change of axial length as an indirect way of understanding how well the treatment is working in inhibiting the myopia progression. Now there is a debate in the field of myopia research in whether we should actually report the absolute and axial, the difference in axial elongation between the treatment versus the control group, or we should report the percentage difference between the two groups. And we do see pros and cons of using each measure. But right now, the consensus is moving more toward reporting the absolute axial length elongation, the difference between the two groups. But I do want to remind you that the absolute axial elongation is actually a very noisy measure for the following reasons. #1, measuring axial length and the change of that is not a linear measure. It's highly dependent on patients' baseline axial length and the stage of a myopia development. So more specifically, let's say we have the same 1 millimeter change in axial length, but if it's changing from a baseline axial length of 20 millimeters and from 20 to 21, its impact, optical impact, will be much, much bigger than the same 1 millimeter change from 25 to 26 millimeter. And also the same thing applies to the stage of myopia. If we're talking about the same amount of axial length change when someone is -1, and that has a much higher optical impact as compared to the same amount of axial length change when someone is -10. And in terms of the stage of myopia development, if we're talking about at the beginning stage of the scleral stretching, and the same amount of axial length elongation will not have the same risk of stretching the sclera and increasing the risk of retinal complication as compared to someone who's at the moderate or the end stage of the scleral stretching. When we're talking about someone reaching a clinical presentation of a posterior staphyloma, any subtle axial length elongation will increase the risk of retinal complication dramatically. So if we're talking about, a 0.13 millimeter per year of axial elongation or inhibition, we have to really look at it under a very specific context. Another thing I want to bring up, which we're going to elaborate in the next slide, is the significant confounding from the physiological or the normal axial growth after birth. But I want to leave it until the next slides. Now let's talk about the complicated myopic, the etiology related to the onset and the development of myopia. We all know that both genetic and environmental factors play a very important role in causing myopia and causing myopic progression. But we also know that depending on the parental myopic history and the age of myopic onset, different patients will have a very different relative genetic predisposition versus some of the later onset myopia are more predominantly influenced by the intensive near work activity. So if we're talking about responsiveness to the intervention, in general, the younger the age of onset, the stronger the genetic predisposition, meaning the onset of myopia and its development is more pre-programmed. And so the patient will be less likely responsive to the same intervention as compared to someone who has a later onset myopia. And the last part of our discussion today will be related to some Ortho-K specific challenges. Even though we have learned dramatically about the overall efficacy of Ortho-K lenses in myopia control, but we haven't actually had a very good grasp of what exactly is causing the anti-myopia effect of Ortho-K lenses. And also this treatment, comparing to that induced by refractive surgery, actually has a very poor predictability, which we're going to get into greater details just in a little bit. So speaking of the confounding from physiological ocular growth, now we have more and more converging data showing that the process of ametropization and the physiological axial growth actually does not stop until around puberty. So the longitudinal data from a mixture of Caucasian and Asian eyes actually showed that for children age ranged 4 to 8 years old, we see on average of about 0.3 millimeter increase in axial length that's not resulting in any myopic shift in their refraction. So these are all of the longitudinal data measured in non-myopic children. We followed them for at least a year and up to 4 to 5 years. And we actually see for this age group, there is a steady and very significant axial elongation that can be compensated by the gradual flattening of the front surface of the crystalline lens. And even for children from 8 to 12 years old, we still see this small but also consistent axial elongation of a 0.12 millimeter per year as a part of the physiological ocular growth. And because of that physiological ocular growth, what we have learned from our previous optometry curriculum, that 1 millimeter increase, every 1 millimeter increase in axial length induce about 3 diopters of a myopic progression, this relationship actually doesn't hold. So from the already myopic population at Berkeley, in this adolescent group, age ranged from 8 to 17 years old, we see on average per millimeter of axial elongation induce about 2.25 diopters of a myopic progression. Obviously, we see a very huge standard deviation here. And in the adult progressive myopia population, and this relationship becomes a little bit stronger, per millimeter increase in axial length equals to about 2.6 diopters of a myopic progression. And so this basically tells us we cannot simply use this 1 millimeter equals 3 diopter rule to predict how much myopic progression our patients had experienced over the course of Ortho-K treatment. So how is this related to our interpretation or the evaluation of the anti-myopia efficacy in the clinical studies? So on the right side from this hypothetical data set, and if we're talking about most of the commonly recruited children for anti-myopia studies usually range from 8 to 12 years old. So in this age group, if on average we see about 0.12 millimeters of axial elongation, regardless of whether they're actually in the control or the treatment group, we should take that out of the picture before we compare the relative difference of axial elongation that's due to the treatment. So if you can see, if we take that 0.12 out of the picture from both groups, and we actually see a very different percentage of anti-myopia efficacy. And the younger the cohort we recruit for those studies, the bigger the confounding effect from the physiological axial growth. So the take-home message from this data set is basically one, do not simply use that 1 millimeter equals to 3 diopter rule. This rule does not apply to most of the population, and it is especially not applicable to younger age cohort. And second, due to the significant individual variability, And even though this is like a common relationship, but its applicability to individual patient is very, very poor. And perhaps one of the most important study published last year trying to investigate the age-related physiological axial growth is this paper, which I have listed the reference here. So this is a group of a little bit over 1,300 school-aged Singaporean children, pretty much aged from 6 to 9 years old. So this is a longitudinal study with a follow-up duration of 5 years. And at the beginning of this study, there are about 40% of the children that are already myopic, which is represented in this red line, the persistent myopic population. And there are about 23% of the cohort that remained as emmetropes, and which is denoted in this black line here. The rest, like 37%, developed a myopia at some point of this during this 5-year follow-up. And not surprisingly, we can see there is a consistent axial elongation even in the persistent emmetropes group. And on average, about 0.12 millimeter per year, which is similar to what we found at our Berkeley Myopia Control Clinic. But surprisingly, I want to bring your attention to this bifurcation point. The point when you see the deviation from of the green line from the black line. So this line is telling us, or the bifurcation point is telling us, for those who developed myopia at the age of 10, they started showing a very accelerated axial growth 2 years at age 8 prior to the refractive onset of myopia. So even at age 8, there is about 0.35 millimeters of axial elongation. That's 2 years before the refractive onset of myopia. So the take-home message from this study is, one, we need to start collecting patients' baseline biometric data way before we start seeing the onset of myopia if measured by the refractive error. And second, if we're using the axial inhibition, whether it's absolute or relative, as a measure of the anti-myopia efficacy, it's a highly age-dependent, and it's also dependent on the stage of their myopia development. Another interesting finding from this longitudinal study is that it's actually the line in this dashed box. So regardless of the age of onset, you can see the turnover point of axial length is clustered around this mean of a 23.85 millimeter. So somehow at this point, the ocular system is running out of the mechanism for the cornea, for the crystalline lens to compensate for the continuous axial growth. So kids started developing refractive myopia beyond this axial length. So anytime we're doing a random screening of kids in their axial length, if we started seeing their axial length getting close to this turnover point, that's really a red flag of telling us we should start educating the parents, we should start thinking about applying some sort of intervention to help slowing down the progression or delaying the onset of their myopia. Any questions so far?
Yes, there has been. And first of all, the question is, are you saying that the axial length measurements for young children during their routine eye exams should become part of their workup at a very young age?
Absolutely. So I actually propose we should start measuring not just axial length, but other biometric data, for example, corneal curvature, anterior chamber depth, and pupil size, etc., as early as the children can actually cooperate. So in our cases, we do have sometimes a 3.5-year-old having pretty reasonable fixation. to be able to get reliable measures, but sometimes for like ADD kid, it probably will not be able to happen until they're 5 or 6 years old. But yes, the earlier the better. That's the only way we can understand after we start orthoking how well the lenses are working in controlling this particular individual's progression.
Okay, terrific. So along those lines, taking all of this information that you encapsulized so beautifully, how do you relate that information to the parent? What do you use predictive tools for them of some sort, or do you just discuss with them where you think this particular child might be headed based on the accumulated data that you have as far as where their endpoint may end up with myopia?
This is a very good question and also a very hard one. So if we're talking about delaying the onset, the biggest factor I look at, if I do have the longitudinal data of their axial elongation, if I do see the axial elongation happened faster than what was reported in this age-specific group, I will bring the conversation up to the parents as early as possible. But I pretty much deliver this conversation to any high-risk family, meaning if one or both parents are myopic, especially moderate to high myopia, I tend to deliver this conversation maybe even before they got married or had kid. But if we're talking about at the beginning of the myopia control consultation and parents are debating which options to choose, and if they're asking about the overall efficacy of each treatment option, I tend to give them the data or the evidence from the clinical studies. But again, the efficacy results or information from those studies are actually comparing the treatment efficacy of Orthok versus another control group. This may not be applicable to that individual patient. So after I start the treatment and at their annual checkup, I tend to use their own previous rate of myopia as a way of judging how well I'm doing for this past years of intervention. So my goal is to control, if I do have reliable refractive data, my goal is to control the refractive progression to about a little bit more than a half of their previous rate of progression. This is because age itself is a protective factor. So in general, we should see a gradual slowing down of progression when they're getting older. So I should be shooting for something a little bit over 50%. If it's we're only having the axial length measurement, I will need to compare what we have learned in terms of the physiological growth of that age group, and also look at the auto refraction over their habitual Orthok lenses, and to see whether we're getting a myopic shift of the over refraction with the same base curve of the lens.
Okay. So we have numerous other questions, but I'm just going to ask you one, and then we can answer the other ones towards the end. And that is related to young children and acquiring their biometrics, in particular the axial length measurements. Do you have a preferred tool with kids that you use?
So certainly any laser interferometry will probably be preferable than an ultrasound A scan for two reasons. One, it's non-invasive, it's much better tolerated, and second, it does have much better precision. But in terms of all different instruments, all using the laser interferometry, I actually don't have a strong preference. The important part is to use the same instrument over time to get an accurate comparison, because now we have learned, even they're all infrared laser interferometry, the axial length acquired from different instruments may not be quite comparable.
Okay, that is terrific. So if we can just continue, and we can circle back with the other questions near the end.
Thank you. So I want to move on in talking about the second factor contributing to the individual variability responding to the same treatment. and which is what we have learned about the mechanism of orthokeratology in myopia control. So comparing to what is achieved after refractive surgery, if you want to pay attention to this post-orthok corneal topographical map and its sagittal profile of a refractive change, we can see there are two distinct differences between the post-orthok change versus the post-refractive surgery change. Number one, orthok lens create a very typical a non-uniform central flattening that is in this oblate shape, in which the biggest magnitude of a flattening actually only happens in the center 1 millimeter of the corneal apex. Beyond that point, we see a very rapid diminish of this central flattening. So this is a very important factor which has been largely overlooked, that the non-uniform oblate central flattening is actually inducing a lot of plus defocus and a lot of higher order aberrations, specifically spherical aberration and coma, all of which had been shown in experimental myopia models to have a strong anti-myopia and an anti-axial elongation effect. And because of the central location of these changes, and they actually contribute predominantly to the image, central image quality, or the image quality change of the central retina. The second distinct difference is the paracentral steepening, which is absent in the case of refractive surgery. And with this paracentral steepening, a lot of Chinese practitioners like to call this as a hot ring or the defocus ring. This is another major source of induced plus defocus and induced positive spherical aberration. But because of its more distal or peripheral location, it has much higher contribution to the peripheral image quality or the peripheral defocus. And lastly, even though it cannot be accurately measured in most of the clinical studies, but the behavioral benefit of orthok lenses, the complete freedom from the constraints from spectacle correction is a huge contribution to the overall behavioral modification for the long-term myopia management. So I want to get into a little bit more details, talking about the whole industry's move into designing the orthok lenses with a smaller optical zone diameter. And the theory is that by making the optic zone smaller, we're able to create a smaller treatment size of treatment zone in the center, and we're able to bring this defocus ring a little bit closer and hopefully inside the pupillary region, so that it actually has a stronger effect in causing a stronger myopic peripheral defocus. So while we're waiting for more solid data from better rigorously designed larger samples clinical studies to confirm the better anti-myopia effect of this newer design, I'd like to provide some extended clarification on the theory behind this motion. So the attempt is try to make the treatment zone a little bit smaller, which on the left bottom diagram, the central blue area is represented as post-orthok, the treatment area, and the red ring represents the paracentral steepening. So a lot of practitioners make a lot of effort of trying to push that red paracentral steepening into the pupillary region. But I want to explain what actually happens when we're making those changes, what would be the impact on the retinal image quality, and how this change is interacting with pupil size. So to be able to explain that, let's take a look at the three different types of rays actually being able to create the image quality change on the retina after ortho-K. So the first type of rays, which is denoted in these green lines, are the paraxial rays or the central rays. These are the rays that's with the incidence angle that's in parallel with the optic axis or the visual axis if we're using approximation. And also very proximal, closely around the visual axis. And these rays mostly receive information from the treatment area and being projected on the central retina. And because these are central rays and pupil size actually play a very minimal role in affecting how much of these rays are actually being able to project to the central retina. Again, keep in mind, even though the treatment area on a topographical map is usually showing in a pretty uniform blue, but there is a lot of plus defocus and a positive spherical aberration just created by the central treatment area with a very typical Ortho-K treatment. And the second type of the rays is what we call the marginal rays or the peripheral rays. These are also the rays coming in parallel with the optic axis, but they're a little bit more distal or being further away from the optical axis. And these peripheral rays receive a lot of information from the paracentral steepening, and they're mostly responsible for creating higher order aberration on the central retina. And this is because the incidence angle is still perpendicular to the first refractive surface. And so unlike a lot of practitioners' expectation that you would actually get a very significant interaction from pupils in projecting or actually influencing peripheral refraction, the pupil size and its interaction with the paracentral steepening plays the biggest role in whether like increasing or reducing the central higher order aberration. And in order to have a significant projection to the periphery retina, we will need to have those rays coming in from an oblique incidence angle. So these are the oblique rays. These are the rays and the angle of incidence controls where is the projection of those rays. And so if we can actually make the lenses, the treatment zone a little bit smaller, so that we bring the paracentral steepening a little bit closer or inside the pupillary region, you can see the extent of this field of view is actually not much affected. This is because the full field from this paracentral steepening is actually influenced by the pupil margin of the opposite side instead of on the same side. So pushing the paracentral steepening a little bit closer to the visual axis or pupil center does not have a big impact on the extent of the peripheral defocus. But the width of the paracentral steepening, in other words, if we can make the area of the paracentral steepening a little bit wider, it would actually create a larger area receiving the plus defocus and the higher order aberration in the periphery retina. So the take-home message from these ray diagrams is that if you are a strong believer that the peripheral myopic defocus is the core anti-myopia, the source of anti-myopia treatment, then pushing the paracentral steepening into the pupillary region will not make a huge difference. But in the future, if we indeed see a better anti-myopia effect from a smaller optic zone design, it's more likely due to its significant contribution to increase the higher order aberration to the central retina. In other words, is the increase in the positive spherical aberration and coma to the central retina. That's basically the increased anti-myopia dosage. So the other point, important thing I want to share with you is that A lot of practitioners are thinking whatever change we had made on the back surface of the lens will be very reliably reflected on the front surface of the cornea once Orthok treatment is stabilized. Is this really the case? And the answer may be a little bit surprising to you. So the topographical maps I'm showing you here are each vertical pair is the same eye wearing the same brand with the difference of a 1 millimeter difference in the optic zone diameter. So unlike what we have expected with a 1 millimeter difference in the optic zone diameter, we expect to see a similar magnitude of change on the size of the treatment zone on the reflected or achieved on the cornea. But this is actually not the case. For all of the subjects we have tested, the actual change on the cornea is much, much less than what we have changed on the back surface of the lens. So the design difference is not the same as the induced topographical difference. And another complementary experiment. Here I'm showing you 5 eyes, all with a baseline myopic refractive error range from -2 to -4. They're all wearing the same brand of Orthok lens with a 6 millimeter optic zone diameter. They're all fully corrected with very good distance vision, but you can see the actual topographical change achieved by the same lens design is drastically different. We have a huge variation in terms of the size of the treatment zone, the width of the pericentral steepening, and the magnitude of the pericentral steepening. So unlike what we have assumed that the relationship between the Orthok and the post-Orthok cornea is kind of like a stamp and a seal, this is not the case. This is not like doing a laser ablation on the stromal corneal stroma, as in the case of refractive surgery. So overall, the hydraulic pressure created by the Orthok lens does not reliably reflect a very precise post-Orthok corneal change. This goes to a very important and also a commonly heard statement or finding from retrospective studies related to Orthok's role in myopia control. There have been multiple reports in saying the baseline myopia played a very significant role in affecting the efficacy of Orthok for myopia control. And in those patients with a lower baseline myopia at the beginning of the treatment, they don't seem to have as efficacious response as compared to moderate to or moderately high myopia. I want to provide some extended interpretation of this finding. Number one, I'd like to actually basically tease down this information and show you an alternative way for the interpretation. So we know if we take a random sample of myopic children and we plot an association of the age versus the severity of myopia, we'll tend to get this pretty significant positive association in which the older the age of the children, the more severe the level of myopia. And this is because myopia is a condition that can only get or either stabilize or get worse. There is no reversibility of a myopia progression. So in this case, we ended up comparing sometimes a 6-year-old -1 with a 12-year-old -4. And as we mentioned before, the younger the age of onset, the stronger the genetic predisposition, the harder for interventions, for any interventions in myopia control for those patients. So if we take the age of onset out of the picture and only look at the same level or the severity of myopia in the same age group, we ended up seeing the opposite effect. the lower the baseline myopia, the easier to stabilize their progression with Ortho-K. This is because the earlier we start the intervention, the better we're able to control the excessive scleral stretching. So we don't want to wait until the scleral structure is being excessively stretched and thinned. At that point, the ocular shape is not even able to maintain just due to the stress from intraocular pressure. So any like a further near work stress or just the stress from intraocular pressure will likely cause a spontaneous axial elongation. So certainly the earlier stage, we can start controlling the excessive stretch of scleral structure, the better the prognosis of a myopia control. Now let me provide an experiment to show you why the theory behind this or backing up this clinical finding may not be the case. A lot of practitioners are concerned in feeding Ortho-K in lower myopes because they assumed a one-to-one relationship between the amount of central flattening and the amount of paracentral steepening. And so in lower myopes, the concern was if we don't have a lot of central flattening, the amount of paracentral steepening may not be sufficient enough to create a strong anti-myopia dosage. This may not be the case, which is demonstrated on the topographical maps on the right side. So each horizontal pair shows you for the same eye, both achieve the full central flattening, basically fully corrected in the center, but having totally different paracentral steepening, both in terms of the shape and in terms of the magnitude. And this is achieved by utilizing a different design. So switching from a spherical design into a dual axis design or a toric VST design. And so by manipulating the vertical return zone depth or reverse curve, we're able to create a different hydraulic pressure distribution, and we're able to create a very different relationship between the amount of central flattening versus the paracentral steepening. So two take-home messages from this slides. Number one, if we were to compare Ortho-K efficacy, we have to take the age of the children out of the picture. We have to adjust that factor. And comparing the myopia controlling efficacy in a 6 years old with -1 versus a 12 years old with -4 is meaningless, because that 12 years old -4 will naturally have a slower progression as compared to the 6 years old with -1. And the second point is that paracentral steepening is not a sole property of central target, central flattening or target correction. It's also highly dependent on how we select the parameters of each Ortho-K brand or design. And lastly, I want to propose, based on what we have learned from Ortho-K studies in myopia control, that instead of using the back surface shape of the lens as the treatment dosage in understanding its effect in myopia control, I'm proposing that we should use the post-Ortho-K corneal shape, what is actually achieved on the corneal surface, as the treatment variable. And more specifically, we need to carefully measure and define what is achieved on the cornea. In terms of central flattening, we need to carefully measure the size of the treatment zone, not the optics zone diameter of the lens. And in case we have a non-uniform treatment, as in this case, the top left corner has a stronger treatment or central flattening comparing to the bottom right corner. So how do we take that into account? And if you take a look at the dashed lines I drawed on the, which is showing on the bottom right half, you can see with the same size of the treatment zone, we can achieve a very different central asphericity we can have a very rapid diminish of the flattening as shown in the dark blue line, but we can also achieve something closer to that by refractive surgery of having much, much less higher order aberration induced. How do we take into account of the asphericity of the treatment zone? And in terms of the paracentral steepening, we need to measure the width of the paracentral steepening or this defocus ring because it's directly related to the area of the plus defocus projected to the peripheral retina. The wider the paracentral steepening, the wider the area of the peripheral retina receiving the plus defocus. And we also need to measure the magnitude of the steepening. That's directly related to the amount of the plus defocus. And also the location, is it more central, proximal to the pupil center, or it's distal or more periphery? Because this is related to the eccentricity, the retinal eccentricity of the plus defocus. So with that, I'd like to summarize that the myopia inhibiting effect, whether it's related to Orthok or other anti-myopia treatment, is subject to have very significant individual variability. And this variability comes from one, we are still having a lot of challenges in having a perfect definition or measure of the anti-myopia efficacy. Axial elongation is not only related to the rate of myopia progression, but it's also related to the physiological axial growth in children. And depending on the age of onset or the genetic predisposition of myopia development, patients are expected to have a various response to treatments. And specifically related to Orthok, in order to better quantify the anti-myopia dosage, we know the dosage comes from both central oblate-shaped flattening as well as paracentral steepening. The central flattening in this non-uniform fashion has been largely overlooked. And because Orthok lenses lacks design specificity, so we will need to make sure we measure the post-treatment corneal shape and use that as the exact anti-myopia dosage or the exposure measurement. And unlike what has been reported in retrospective studies that lower myopia do not respond to Orthok for myopia control, this is actually the opposite. After adjusting for the age factor, the lower the baseline myopia, the earlier we start the intervention, the better the prognosis in controlling further progression. With that, I thank you for your attention. Now we have a short info session from Andy Jackson of ABB Optical, so I'd like to save all of the questions until the end of this webinar. Thank you.
My name's Andy Jackson. I'm a director of specialty vision products, ABB Optical Group. I sold my specialty lab to ABB 4 years ago, and I saw just their breadth of their portfolio when I came on board, and I was amazed because they had acquired a lot of labs over the years, and they have this incredible amount of products. And so over the past 3 or 4 years, we've tried to get the best ones, put them out front, and try to educate the doctors to learn how to fit them and offer the best products out there. So you can see we carry 12 different scleral lenses. We carry Paragon CRT for Orthok, we carry Euclid for Orthok, synergized hybrids. We have just an incredible breadth of portfolio, but we don't want to just show you our products and sell you a lens. We want to educate you and make you better at it and help you have a better specialty practice. And you can look at our catalog on the left on this slide, and it shows all the things that we do to try to help you get there. We do wet labs, we do lunch and learns, which we basically, after this pandemic, we've pretty much gone to virtual lunch and learns. We're doing more now than ever. We do staff trainings, and we'll kind of get into all the different educational things we do to help you grow your practice. So it's pretty exciting that everybody's embracing this. This is the backbone of the ABB specialty group. This is our consultation team, and we have the best consultants in the business, and I'm sure every lab says that, but we have 12 consultants. They're all highly seasoned. Down in the left-hand corner, Joe Hansen worked for me for 35 years. I've known most of these people. Just recently, a year ago, hired in the upper right-hand corner, Dee Reyes, who we hired her from Synergize. She's a hybrid expert. She's an incredible fitter. She's become our professional education consultant. And all of these people are great assets to you when you want to learn about lenses. You want to help with the patient. They're there. Their extensions are on here. They're easy to get a hold of. These are some of the educational tools I was talking about, the lunch and learns, the wet labs. We have scleral lens boot camps 4 times a year. I do 1 a quarter. I live in Nashville. We do them in Nashville. We bring in 9 practitioners that want to, really specialize in scleral lenses. We spend a weekend getting trained, learning how to bill and code, all the things you need to do to be successful in fitting scleral lenses. We have virtual staff trainings. Dee Dee's got videos on our website for insertion and removal, anything from beginning to end that your staff needs to learn. And then we also have our optometry student challenge for our 3rd and 4th year students. And this year we've got a separate category for Ortho-K. We're pretty excited about it because the interest level from students is going through the roof on Ortho-K. Again, this is Dee Dee. I was talking about her. She's now over all the training and all the education for us, and she can do virtual trainings with you. If you've got any specific product that ABB has, she can do training on that product, or if you just want to hear about all the portfolio of products that we have. I mean, the beautiful thing about ABB, if you want to use a product, we don't have to lead you into a certain lens. We can listen to you and decide which lens best fits you and best fits your patient's needs, and then we can offer you that. We have loaner trial sets on all the different lenses out there that we have in stock. So Paragon and ABB are tremendous partners together, and we do tons of CRT. Our consultants and Paragon's consultants are constantly talking on a day-to-day basis. You can order your CRTs from ABB, you can order them from Paragon and still have them billed through ABB. We just want to help make you more efficient and make your specialty practice more efficient. And the beautiful thing, once you get certified with CRT, Paragon has a beautiful onboarding, and they'll come in and they will teach your staff and teach you how to schedule, how to bill, how to get started with CRT and Ortho-K, and how to be successful at it. They're just not trying to sell you a lens. They're trying to help you be successful, just like we do with our other specialty products. So, and this kind of summarizes everything I talked about. We've got 2 labs. We manufacture in Alameda, California, and in Kansas City, Missouri. We've got all the loaner fitting sets that I told you about, that any kind of lens you want to use. If you don't want to buy a set, we can certainly loan you one so you can get your feet wet. Wet labs, lunch and learn, staff trainings. We continue doing the webinar series, and we've great speakers like we had tonight with Dr. Liu. We've got Stephanie Wu coming up next quarter. And then we have a specialty practice management, and here it is. I'll let Craig talk a little bit about that. So exciting things to come. We appreciate you being on the seminar, and I think they're going to go over some questions with you. Craig?
Thank you, Andy. And don't run away, people. We have a lot of interesting questions, and if you have any that you want to ask of Dr. Liu, please type them in to the question box. Dr. Liu, these are kind of all over the place. There's a number of different ones, so I'm going to try to capsulize some of them into one.
Sure.
But in particular, there's a lot of interest in your discussion about the smaller treatment zone. In effect, does that smaller treatment zone have any impact on vision, such as looking at halo and glare and flare, that type of thing? And also related to that, does the smaller optic zone, it does not mean that controls the myopia control better, but it would not hurt.
So first part of the question related to visual quality with the smaller optic zone. And it's also very surprising to us, out of the 20+ subjects we have tested, And we are doing this interocular comparison. So basically for each subject, they're wearing a 6 millimeter OZ lens in one eye and a 5 millimeter OZ lens in the other eye. And we monitor them for a while, wash them out, and switch over so that both eyes get to experience both lens designs. But for each pair, they actually did not know which lens is actually the smaller optic zone. And these are all optometry students. And so they're actually very professional subjects, and they're supposed to be able to guess based on their knowledge. But surprisingly, most of them cannot really tell which eye is wearing the smaller optic zone diameter lens. And in fact, many of them had reported better vision with the smaller optic zone design, because as you can see from the first and the second and probably the third vertical pair, for the smaller optic zone, especially for those moderate and high myopia, there is a much less chance of having a pseudo central island, where the treatment is more thorough at the corneal apex. This is where they use mostly for their distance vision. So to answer the question in short, we do not still see a significant negative effect from the smaller optic zone design. The second part of the question is related to whether it actually caused a better myopia control effect. Again, this is something I want to emphasize. We're waiting for a more solid result from, it has to be a randomized, a prospective study. It cannot be from retrospective study because it's subject to a lot of selection bias. And if indeed we see better results from the smaller optic zone design, I'm proposing it's largely due to its impact on the central higher order aberration rather than its impact on the peripheral defocus.
Okay, great. If I could just ask you a personal question regarding when you were looking a little bit later in the presentation tonight and talking about looking not just at the maps itself, but looking at the grid below and what the impact is of the nature of the optical effect. It was the one in particular right there where you are looking at, you have the same basic treatment zone size, but the shape of it is significantly different. And so my question to you is, do you recommend when you are teaching students or teaching somebody in your myopia control clinic that they spend as much time looking at this grid as they do at the topographical map for their data inputs?
No, I think the number one thing I teach my students is to start early. In our experience with hundreds, if not thousands of Ortho-K patients, if we are able to start early, usually we're able to slow down and even stabilize their progression with a very high chance of success. In our experience, if we start late for those moderate and high myopia, in general, we're not able to control the progression as effectively as in the lower myopes.
Okay, good. So here's a quick one. What type of anterior camera do you use?
An anterior sex, like a slit lamp camera?
Yes.
Well, we, because I practice at Berkeley Clinic, we have the standardized IM 900 as part of the hack strike accessory. But I don't think it matters. And in fact, we actually had a loaner, newer model of the Matmont, the new topographer, the Meridia. And Meridia actually has a built-in anterior sec camera, and that's actually working pretty well. As it generates a very amazing anterior sag videos and images. And I think Matmont is actually trying to get some software updates so that we can actually export those videos out of their software.
Right. And that's really a good point, that the topography and tomography manufacturers right now are incorporating the ability to capture photos that are extremely high quality and very easy at the same time. The one question here is, regarding, are there any negative control factors in hyperopic kids that inhibit axial length increases?
This is a very good question. From a myopia researcher standpoint, myopia and hyperopia are actually two totally different disease entity. They're not on the opposite spectrum on the same scale. And if we look at, that's part of the data I'm not showing here, but from the longitudinal data from Singaporean children, and looking at those hyperopic kids, the actual rate of axial elongation as a part of the age-related change is very similar to that of the persistent ametropes. It's just their corneal curvature is not, I think it's changing a little bit differently. And for some reason, for those moderate and high myopia, they're not able to utilize the axial elongation as part of the ametropization process. So there has been theory in saying hyperopia is more of a visual cortex problem versus myopia is a retinal or like a local ocular problem. So in short, I don't think they are on the opposite spectrum of the same scale. They're actually two different diseases.
Okay. And Maria, how do you set the power with a patient who is using atropine 0.05% and has very large pupils, and their vision is affected by that? Best vision in right eye is 20/50, and even with a -1, the improvement is only a line or so better.
Again, sorry, what's the question again?
How do you set the power for a patient who is using atropine 0.05% and has very large pupils, and their
The power of Orthok lens?
Yes, I think that's exactly what is being asked.
You mean in the case where we combine a 0.05% atropine with overnight Orthok?
I believe so. The question, I read it to you, was word for word.
Okay, so
And
I think the question, this is my interpretation of the question. I think the question is asking, how do we increase the Jensen factor or the compression factor to minimize the induced higher order aberration due to a very enlarged pupil size? So in that case, yes, I may actually be a little bit more aggressive in adjusting my Jensen factor to have the base curve of 0.1 or 0.2 flatter, so that I'm actually trying to bring the corneal apex to be slightly overcorrected to compensate for the huge amount of positive spherical aberration from the enlarged pupil size. Okay,
good. And here's a fairly basic question, but the one that's on the top of everybody's mind at the moment. And is there anything that today you are advising your staff to be extra concerned with when working with new patients for contact lens insertion and removal for Orthok? This is directly related to COVID.
There has been pretty extensive studies, both especially in China, because China has like a 2.5 million Orthok wearers, and their pandemic actually happened several months in advance of us. So this is what I would suggest. First of all, Orthok lenses as part of a GP material, it actually has very minimal water content, and so it doesn't have the sponge effect as in the case of soft contact lens. And if we're very concerned about contamination or like a viral, like a cross infection, I think hydrogen peroxide is a good option, and we just need to make sure we're not skipping the digital rubbing portion of that. And if there's any concern, a thorough rinse of the lens would get rid of anything on the lens surface. Again, there is no risk of having anything being absorbed into the infrastructure of the lens. So digital rubbing, good disinfecting, and thorough rinsing would do the job.
Okay. And in particular, as far as that would be helpful for the patient, is there any changes in the procedures for teaching application and removal that is taking place now versus 3 months ago?
So that I actually don't have much experience yet. The Berkeley clinic had just resumed partial capacity as of last week, and we are not actually working with students just yet. So it's mostly just direct patient care from faculties. At this point, I'm doing all of my INR training myself, and I'm not doing anything extra other than just disinfecting the station, my room, after each patient, and wearing my PPE.
Yep. So for the INR, is the patient wearing a mask?
Yes.
Okay. Okay, I think that that's kind of the areas of those questions that would come up. So we're about ready to close. Do you have any last minute comments that you'd like to make?
Yes, and so I think I want to make clear that I may sound like not as optimistic as in some other or related to Orthok, but I do want to make sure we understand acknowledging what we don't know is a big step in like a research advancement. And we have to be honest in understanding there is a lot we don't know about why Orthok is working in myopia control. We cannot afford to think that we have figured everything out. So as I said, Orthok is not working as predictable as refractive surgery in creating a very precise change. We have to be mindful of that and making sure we understand sometimes it's not just about switching to a different brand. It's more about our thorough understanding of each particular design and being able to choose the optimal parameters within that design.
Right. I will say that, you know, it sure doesn't come across with that from what you said tonight. That what I'm hearing is that the science is advancing. There are more tips related to evaluating the results off of both the map and looking at the grid and the changes that are taking place. And the ideas that you're proposing relative to the different optical zone sizes is just adding to the science. I think that it's really terrific that we're seeing this science advance and we're learning more all along the way about how Orthok can be used in practice and really with more predictable results, hopefully going forward.
Yeah, I totally agree. And again, we need to start early. That's why I enjoy the movie Inception so much. We need to really plant the idea to the parents of the myopic children as early as possible, probably way before they start noticing a myopic shift of the refraction. As shown in this study, the accelerated eye growth happened a couple of years prior to the refractive onset of myopia. So the earlier we can start collecting their data, the better we're able to understand whether we're applying the best possible treatment to those patients.
Okay, terrific. We really want to thank you very much for an enlightening and educating evening tonight. Once again, for myself, for Andy Jackson, and for others at ABB Optical, Dr. Liu, thank you so much for really helping us to better understand orthokeratology and myopia management.
My pleasure.
Good night, everybody.